Okay, we are back. Professor Tabs is back. Pathology 3. We're talking about some of the things that you should be reading about. Are you reading about injury mechanisms, reversible injury mechanisms? What are some of the types of injury mechanisms that are reversible? How about decreased ATP, mitochondrial damage, increased intracellular calcium, increased free radicals, increased cell membrane permeability? But what happens at the subcellular level? What are the responses to injury at the subcellular level? Well, you have to read about these in detail, but let's just name them. Lysosomal autodigestion, smooth endoplasmic reticulum activation, mitochondrial swelling, and what are the thin filaments? Actin and myosin. Then there's also cytoskeleton breakdown. What are the intermediate filaments? Keratin, desmin, vimentin, neurofilaments, and glial filaments. You better read about all of those. Okay, let's talk a little bit about irreversible cell injury. Of course, we're talking about severe membrane damage, marked mitochondrial dysfunction, rupture of the lysosomes, and nuclear changes. Okay, and moving on. Well, we have to understand the concepts of karyolysis, pycnosis, and karyohexis. So basically, just to summarize these, we'd say that karyolysis is the nuclear fading, pycnosis is nuclear shrinkage, and karyohexis is nuclear fragmentation. Now, while these all lead to nuclear dissolution and an anuclear necrotic cell, let's discuss a little bit more about the difference between karyohexis and karyolysis. Karyolysis is the complete dissolution of the chromatin of a dying cell due to the enzymatic degradation by endonucleases. And the whole cell here will eventually stain uniformly with eosin after karyolysis. And it is usually preceded by karyohexis and occurs mainly as a result of necrosis. While in apoptosis, after karyohexis, the nucleus usually dissolves into apoptotic bodies. So now you know it all. And can you guess where you might see an example of karyolysis? Well, one good example, of course, is someone who had a heart attack, a myocardial infarction. And you can't see this micrograph here, but I'm looking at a micrograph that shows karyolysis and contraction band necrosis and ischemic cardiac myocytes in an individual that had an MI. And are you familiar with necrosis and apoptosis? Let's talk about some of the big points here. Of course, these are very different. One leading to inflammation, the other not. Necrosis leads to inflammation, basically because with the breakdown of the plasma membrane and the organelles, there is a leakage of the contents, and this results in inflammation, attraction uh, of the immune system, inflammatory processes. But in apoptosis, there is cellular fragmentation, but there's no apoptosis. What happens is in apoptosis you would have the condensation of the chromatin, and then you would see membrane blebs, small blobs breaking off, and then they would break into apoptotic bodies, and then there would be normal phagocytosis of these apoptotic cells and fragments by the phagocytes, but there would be no um, inflammation. Whereas in necrosis, you'd first have a swelling of the endoplasmic reticulum and the mitochondria, and with progressive injury, you would have breakdown of the plasma membrane, organelles, and nucleus, and leakage of the contents, and then you would get the inflammatory response. So they're very different. And of course, you'd have the cytokines coming also, all these difficulties that will result from necrosis. So that's why apoptosis is not calling in the inflammatory response. So can you think of an overview of apoptosis, talking about it as being programmed cell death? What is the programmed cell death? This is an active process which is regulated by genes. It involves RNA and protein synthesis. How about the morphology of the apoptotic cells? What happens? Remember that the cell shrinks with dense eosinophilic cytoplasm. There is condensation of the chromatin, fragmentation, and then there would be membrane blebs. And then the apoptotic bodies would be phagocytosed by macrophages, and of course no inflammatory response. And continuing on with our discussion of apoptosis, or apoptosis, however you like to call it, remember that there are two types of apoptosis. We have intrinsic and extrinsic apoptosis. And then there's also pathologic apoptosis. But first let's talk about the intrinsic and extrinsic apoptosis, and they follow exactly with the definition. Remember, these two pathways of apoptosis differ in their induction and regulation, but both culminate in the activation of executioner caspases. So here we have those caspases, the executioner caspases, which result in the breakdown of the cytoskeleton, or the activation of endonucleases. So we can think of the intrinsic pathway as involving the mitochondria, so we call it the mitochondrial pathway. And what is involved here would be, as with cell injury, growth factor withdrawal, DNA damage, for example, by radiation, toxins, free radicals, protein misfolding, which results in ER stress, and on the other side, we have what's called the death receptor pathway, or the extrinsic pathway, and this would be coming from external signals, and would be the programmed signals. So in this case, we would see receptor ligand interactions, FAS, tissue necrosis factor receptors, and this would be the extrinsic pathway. So in the case of the mitochondrial pathway, we would see this breakdown starting with cytochrome C and other pro-apoptotic proteins, and then leading to initiator caspases, leading to the executioner caspases, which would then lead to endonuclease activation, DNA fragmentation, and membrane blebs. And the same result basically, but in the extrinsic pathway, we have the receptors that the receptor ligand interactions, FAS, TNF receptor, and we have the adapter proteins leading to initiator caspases, leading to executioner caspases, and then the breakdown of the cytoskeleton, again leading to the membrane blebs, which would become apoptotic bodies, and then there would be ligands that would meet the phagocytic the phagocytes So these receptors would be connecting to the phagocytes, and then that would be the end of it. So what is pathologic apoptosis? Well, this is a gray area between apoptosis and necrosis. This is a toxic effect on the cells, for example, from chemicals or pathogens, which results in duct obstruction, tumor cells, and we should understand that this kind of sort of in the middle. So we have discussed apoptosis, or the normal program death, in different types: internal, um, intrinsic, extrinsic. And how about necrosis? Can you remember the types of necrosis, morphologic types of necrosis? See if you can name a few. And can you name some examples? Well, we have coagulative necrosis, liquefaction necrosis, such as what occurs in the brain, caseous necrosis, which has a cheese-like appearance, which you might see with tuberculosis, fat necrosis, which might occur in the breast or any fat, and fibrinoid necrosis, such as with rheumatoid, or which is non-specific, and gangrenous necrosis, which would be seen in the extremities or the bowel, and this is non-specific. And there are basically two types of gangrenous necrosis. We have dry gangrenous necrosis, which is a coagulative necrosis, and wet gangrenous necrosis, which is a liquefactive necrosis, which follows. So let's first talk about coagulative necrosis. So let's discuss coagulative necrosis and compare it to liquefaction necrosis. Liquefaction necrosis occurring in the brain, and coagulative necrosis occurring in the kidney. So first, let's discuss coagulative necrosis. And so under what conditions would you expect to find this in the kidney, for example? This would occur, coagulative necrosis would most commonly be caused by hypoxic conditions or ischemia. And how is it characterized? How does it look? It has a ghostly appearance of cells under the light microscope in the affected area of the tissue, kind of whitish yellowish, and the injury denatures the structural proteins as well as the lysosomal enzymes, thus blocking the proteolysis of the damaged cells. But what happens to these lysosomal enzymes? What do the lysosomal enzymes do here in this case? The lack of lysosomal enzymes allow it to maintain a coagulative morphology for some time. So it does not completely melt. They just sort of just hang there. They just stay there, dead cells not doing anything. So the proteins have unfolded and they've lost function. They're just not working. But how about in the case of liquefaction necrosis, ischemia in the central nervous system? Here we're having it causing liquefaction necrosis, and in this case the lysosomal release of digestive enzymes turns the tissues into a liquid viscous mass, and the loss of tissue architecture means that the tissue is essentially liquefied. So in this case we see that the lysosomal enzymes are working and they're digesting. Their enzymes are working to digest in the brain like an acid. But in the kidney, in the case of coagulative necrosis, it's denaturing the structural proteins as well as the lysosomal enzymes, but the cells are just hanging out there without moving, and it allows it to maintain a coagulative morphology for some time. So ischemia in the kidney and brain have a very different result.